The case we will be discussing tonight raises the matter of timing. The final diagnosis was histologically proven. As always, before we go through the case, may I kindly remind those who have access to the case on CMRAD platform to follow the case discussion step by step with the other participants. As previously, you will be asked to select the correct answer. Only one answer is correct using a multiple choice question. You will have 20 seconds to do so. It's completely anonymous, so don't be shy to participate. I hope we will have all the participants responding to MCQ questions. So thanks to Frederick for handling the MCQ and the polling system. Then let's get started. Let me share my screen right now. We are now on the CMRAD platform, and the case is keep an eye on it. So we will straight go to the review mode. And we will start, sorry, first of all, I have to tell you the clinical story. It's about an 87-year-old woman brought to the emergency with confusion, nausea, vomiting, and disturbances of consciousness. She had no previous known neoplasm. Clinical exam was normal, and the neurological exam also at admission was normal. She tested negative for COVID-19, and her chest X-ray was normal. But she reported progressive loss of vision since more than 1 year, and she was quite blind on both eyes at the time of admission. So let's review the MR images in the review mode. We will start with the diffusion images, and I will scroll the series from the bottom to the top. And what we find here is a hyper signal, which is not as hyper signal as what we used to see in stroke, but there is definitely something abnormal over there. It involves the cingulate gyrus anteriorly on the right side and nothing else. So now we move to the T1 images axial plane. Let me change the window level here. We can see that there is a hyposignal over the area that was bright on diffusion. And if we move on to the gradient echo images, we don't see any dark signal at this area. And then let us move to the axial flare images. Or maybe you would like to see the Adc map. This is the Adc map. And it doesn't show clearly a diffusion restriction over there. There is a mix of diffusion velocities with some restriction at the periphery of the lesion and increased diffusivity in the core of the lesion. Let me see, what about the coronal flare images? Okay, we can see the lesion here, which appears hypersignal on flare images, but with mixed signals. As you can see, there is a bright signal in the core of the lesion, and you can see here nicely the involvement of the cortex. But there are also some other white matter lesions that can be attributed to leukoariosis. As you can see here, confluent white matter lesions around the ventricles in the deep white matter but this one is clearly different from the other white matter lesions. So would you like to see if it enhances? I guess so. Also pay attention to the pattern of enhancements, as you can see here. Part of the lesion is enhancing with a patchy pattern of enhancement that involves the leptomeninges, I think, and maybe partly parenchymal. So, given the clinical story and the MRI findings that I have just described to you, what do you think is the solitary enhancing lesion? Because there was no other enhancement all over the brain. Only that one I showed you. So what do you think is the lesion? Is it a focal ischemia with blood-brain barrier alteration, or solitary metastasis from a known cancer, a known origin, or maybe a glioma like glioblastoma or other gliomas, or a primary central nervous system lymphoma, or primary central nervous system vasculitis? You have 20 seconds. Thank you, Frederick. Okay, we have the results displayed, and half of the participants think that this is a primary central nervous system vasculitis lesion. Okay, but the right answer is, hold on. I won't tell you right now. Don't be so quick. Let's keep the suspense. And the next question is right there. What would you suggest first to get close to the final diagnosis? If you want to support your choice, like primary central nervous system vasculitis, what would you do first? Next to the MRI review. Would you suggest doing a whole body PET scan? Would you suggest complementary MRI techniques such as perfusion and or spectroscopy? Would you review the previous brain imaging exams? Or would you suggest doing a lumbar puncture? Maybe you would suggest nothing, just getting rid of all the previous suggestions. Let's see the results. Okay, some of you would suggest performing additional MR techniques like perfusion and spectroscopy, which is a good suggestion. And others suggest reviewing previous brain imaging exams, which is also a good suggestion. And I see that there is one who is who suggests not to do any of these, but just to tell about the diagnosis in the report. Okay, let's see. Reviewing the patient's medical imaging records is always a good thing to do when reading out the exams. It really helps sometimes to figure out the complete story. For instance, in this case, we found 2 head CT scans that were done prior to the MRI. And let us review the first one, done in 2020. And we remember also that the patient reported loss of vision, a progressive loss of vision since more than 1 year. So we will pay special attention to the orbits and eyes. First of all, look at the single edge iris here. where we saw on the MRI the lesion standing there, but we can tell if there is any hypodensity over there. We can just tell that the sulcus adjacent to the cingulate gyrus is not does not show any mass effect. Then let us move to the orbits and see what's going on. Let me change a little bit the windows to see the orbital fat. Okay, there we have the optic nerve, we have the eyeballs, and we can see that the contours are normal, and there is no abnormal density within the vitreous. You can see the hyperdense lenses there. It's symmetrical and it looks normal. Then let us move to the next CT scan that was done in January this year. At the level of the cingulate gyrus, it's again hard to tell, but we see that maybe there's a small mass effect on the sulcus anteriorly to the cingulate gyrus, but it's not that obvious. And when we go down to the orbits, what do we see? I can tell you that if you look at the lens, you don't see the right lens anymore. It's kind of destroyed, partly destroyed, and you can identify it as well as on the previous scan. And if you look at the eyeball, and you see that there is kind of thickening of the walls of the layers, and maybe there is some increased density in the vitreous chamber. And I did it before. I took a region of interest to see how different were the densities between both eyes. And I saw that there was an increase of the densities in this eye. And maybe you can see here that there is a kind of focal thickening of the posterior layers of the eye. So at this point, it was important to mention in the report that there is something going on there, and to be able to differentiate between the anterior eyeball pathologies and the posterior eyeball pathologies. And you will see now what happens on the MRI. If we go back to the MRI and look especially at the orbits, what we will find is really impressive. Starting with diffusion images, and what you see here is an infiltrative disease and touching the posterior layers of the eyeball and extending to the retrobulbar fat as well as to the optic nerve head over there. So given these new findings and description of eyeball abnormalities, and you can see that the left eye is also abnormal because it was reported that there was a hemorrhage in the vitreous chamber of the left eye. So both eyes are involved, but the right one is more severely involved. Then, given the clinical story and the MRI findings, what do you think is the solitary enhancing lesion again? So we come back to the first MCQ with the same choices, and now you may adjust your choice and I guess choose the right answer, the final diagnosis. Please, Frederick. Do you still think of ischemia, focal ischemia, solitary metastasis, glioma? primary CNS lymphoma or primary CNS vasculitis? What is your final diagnosis? Let's see the results. Okay, well done. Most of you have chosen a primary central nervous system lymphoma. A chorioretinal biopsy of the left eye disclosed histologic features of ocular lymphoma. Thus, the lesion in the brain was identified as a secondary location of a primary intraocular lymphoma. As you may know, intraocular lymphoma is a subset of primary central nervous system lymphoma. It may occur with or without brain involvement, depending on the course of the disease. So let me share my first slide, which shows the first teaching point for tonight. Okay. Then intraocular lymphoma is also called primary vitreoretinal lymphoma. It's considered as a primary central nervous system lymphoma because it involves the central nervous system part of the retina. And it's a rare condition, but the last years have seen an increase in the number of cases. And you may know that immune deficiency is a high risk factor of developing intraocular lymphoma. It's a large B-cell lymphoma, mostly occurring in elderly patients. And it's often mistaken for chronic uveitis with resistant to treatment. Long-standing chronic uveitis may be considered as primary intraocular lymphoma. 15% of patients with primary central nervous system lymphoma will develop intraocular lymphoma, and conversely, 65 to 90%, that means pretty all patients with intraocular lymphoma will develop CNS lesions. And the association between intraocular lymphoma and CNS lesions is often fatal, as in our case, because this woman died just 2 weeks after having done the MRI, unfortunately. And intraocular lymphoma is often bilaterally, typically, as you can see on these images. You have the posterior eyeball layers involved. And when the lesions spread into the retrobulbar fat, it goes direct to the CNS in the cerebrum, and it can follow hematogenous, perineural, or contiguous routes to get into the CNS. And you see the aspect here on T1 without contrast and with the fat, the adjacent fat, and you can see the involvement of the posterior eyeball with extension around the head of the optic nerve. And then when you get the association between the eye and the brain involvement, it's pretty almost fatal. And so it starts as a nodular lesion at the posterior eyeball layers, and it goes into the choroid and then into the episcleral space and spread around the head of the optic nerve. Advanced MR techniques may help in differentiating CNS lymphoma from other diseases such as gliomas, vasculitis, and even infectious diseases. This paper here describes 3 different patterns of first pass contrast bolus perfusion in lymphoma lesions. Those patterns vary depending on the tumor morphology, the size of the tumor, on whether the tumor is solitary or multifocal, and it depends also on the width of peritumoral edema. The typically lesions from lymphoma will show reduced perfusion in the core of the lesion and increase perfusion in the periphery of the lesion, at the periphery of the lesion, which correspond to the pattern called by the authors RCBV sun. In my opinion, I think it looks more like an eclipse than the sun itself. But anyway, this was the name given to this pattern of RCBV map showing how the lesion appears on RCBV maps. And then if you look at the curve over here, at the time intensity curve in the lesions, you see that it goes up after the peak above the baseline, and it goes up, drawing a shoulder, and that is why this pattern is called TSIC shoulder, because it goes up, and it corresponds to the extravasation of the contrast in the interstitial spaces. And this is really typical for lymphoma, and it makes the difference with glioblastoma, for example. Then a spectroscopy can also add some nice information to help getting close to the final diagnosis, because it's a nice technique and it allows you to pick up the chemical compounds in a localized volume of tissue. And when you're able to analyze the chemical compounds of the lesions, you will see in lymphoma that you have a huge peak of lactate and lipids, and a drop of Na and acetyl aspartate. And the residual peak is made of glutamine and glutamate complex. And then you have a huge peak of choline that covers the peak of creatine. You have the normal appearance of the brain spectrum here at the same location. And this is what I got in one of another case from my collection with intraocular lymphoma on the left side, and spread to the basal ganglia and to the deep white matter there. So I think in sum, the timing was crucial in this case, because the early diagnosis of intraocular primary lymphoma might have avoided the spread into the cerebrum. Unfortunately, as I said, the patient died a couple of days just after the brain MRI. And the association of orbital involvement displaying obvious features of primary lymphoma should have highly suggested that the brain lesion was also part of primary central nervous system lymphoma. So please keep an eye on the eyeballs, because trouble in the brain may come from there. Thank you.
Thank you so much, Patrice, for an excellent lecture again. And we would like to open up for questions. So if you have any questions, feel free to write them in the chat, and remember to select to write them to all panelists and attendees. But what about MR spectroscopy? Are there any studies showing good results regarding sensitivity for detection of primary central nervous system lymphoma? And maybe you already answered this, but I will ask the question anyway.
Thank you. No, I mean, there is no real specificity of the abnormalities that are displayed in the spectrum corresponding to primary central nervous system lymphoma. But you can make the difference between primary CNS lymphoma and glioblastoma, for example, or primary CNS lymphoma and vasculitis. You can make the difference using spectroscopy, because the changes are not the same. And make sure when you perform spectroscopy in a patient with lymphoma, make sure that he hasn't received corticoids, because corticoids will change the metabolic profile of the tissue. And even in the lesion, it will change the metabolic profile, and you won't be able to make the diagnosis using spectroscopy.
Thank you, Patrice. Any more questions? Okay. So if no more questions, I'd like to thank Patrice, and like to thank all of you joining this webinar tonight. And we keep you posted about the next webinar. And the link to this webinar recording will be posted on the case page on Collective Minds. And if you don't have the account, all doctors are welcome to register for free at cmrad.com. And also remember that if you find a tricky case, feel free to share it with Collective Minds to get feedback from Professor Jissendi and others, and use as a complement to your existing diagnostic workflow. And thank you again, and see you next time. Good evening, everyone.
Thank you, guys. Have a good night.
Thanks so much.